Welcome, everybody. My name is Dr. Jasleen Chhatwal. I'm the Associate Medical Director and the Director of the Mood Disorders Program at Sierra Tucson. We'll be talking today about the Tiramisu approach to treatment-resistant depression, integrating psychotherapy, pharmacology, complementary and alternative modalities, as well as neurotherapeutics. This talk today is sponsored by Sierra Tucson. Some instructions before we begin for submitting questions and answers, or at least your questions. You can submit a question on the bottom left of your screen at any point during the presentation. The questions will all be, I'll attempt to answer them during the last 10 minutes of the program. We may not get to all of them, so I'll try and prioritize things based on how different the questions are. So you can also find a PDF of the presentation under the headshot image located on the left of your screen. And for any help that you may need during the presentation or even after, you can email Melissa Pingaro, and her email is there on your slides. And then finally, to receive credit information, which is very important, please make sure you watch the entire program through the question and answer section. Do not leave your console. And to make sure that you complete the evaluation as well. And if this is your first time attending a webinar in 2019, you'll need to create a new NACME account. And after that, for all subsequent webinars, I think you can use the same account. To make sure that you get that credit certificate, you'll complete the evaluation and then be able to download or print your certificate. Again, thank you so much for joining us, and hope this is beneficial as we move along. I personally do not have any financial disclosures regarding this presentation. And sometimes when I talk about this presentation, I do like to give a personal disclosure, and that is that the topic of the presentation, the Tiramisu approach, I often get questions about what is the Tiramisu approach? And people wonder if I've come up with some new scientific theory, and I would say I am probably not quite there yet. This is more a personal sentiment. I realized when I was asked to do this webinar and a similar presentation before, I was in the midst of having a lot of almost withdrawal delirium from not being able to eat tiramisu since I turned vegan about 3 years ago. And so at the time that I was asked to do this presentation, I thought about my not-so-secret obsession and decided that there was some connection between baking a tiramisu and treating mood disorders. So you'll learn a little bit more about that as we go along and hopefully find that there are some correlations that make treating mood disorders sort of a tasty and baker-ridden perspective. So talking about objectives, we're going to go ahead and define depression and treatment-resistant depression. We'll try and understand challenges inherent to treating treatment-resistant depression. Also review the current evidence and consensus-based treatments for treatment-resistant depression. And finally, discuss novel as well as experimental approaches for this difficult-to-treat depression. So talking about major depressive disorder in DSM-5, as we all know, there's some criteria for major depressive disorder, the main one being depressed mood and or anhedonia. So we need one of those two present, and then a total of 5 symptoms out of the 9 that are listed on the slide for at least a 2-week period for a patient to be designated as having major depressive disorder or a major depressive episode. And then there's other depressive disorders in DSM-5, which are listed on this next slide. These all differ in duration, timing, presumed etiology. And I personally tend to think of mood disorders in a lot of different ways, and maybe more from a pathophysiological standpoint. But a common way to look at mood disorders is to think of them in a continuum. In DSM-4-TR, we had a separate criteria of depressive disorders and bipolar disorders, which were all clumped under the mood disorder subsection. But now in DSM-5, we've gone ahead and put depressive disorders in one section and bipolar disorders in another. And we're not entirely sure pathophysiologically how different they are, but the main reason for doing that was that we do know that neurobiology and physiology-wise, and also from a genetic perspective that they are fairly different disorders. But then again, looking at this other slide about continuum of the mood disorders, you realize with the new mixed features category that there is still some overlap, because with our newer understanding, we think that you can not only have mixed features when a person has bipolar disorder and is on the manic spectrum, but also the depressive spectrum, but then also with patients who just have unipolar depression, that they too can have those mixed features. So in some ways, our understanding of mood disorders is growing with every passing year and every passing study into physiology, genetics, biology. So we would see that over the next few years, there will be a lot of changing perspectives on this continuum. And just putting this out there, because when you start looking at treatment-resistant disorders, whether that's treatment-resistant depression or bipolar disorder, there's slightly limited research out there, which is essentially limited by these very complex criteria for diagnosing and treating these disorders. So looking at treatment-resistant depression, it has multiple differing definitions. There's some consensus, which is really just based on the STAR-D study, which is a famous study in psychiatry regarding treatment of depression. And as you see, the main definition is a failure to achieve remission with 2 or more adequate antidepressant trials, but these have to be of different classes. And when we look at the results of patients who are treated with depression, we realize only half to 2/3 of them respond to their first antidepressant or their antidepressant treatment at all. And then majority of the people with major depressive disorder actually do not reach full remission. And so that really is the hard part, that if even after 2 trials, we're only able to treat, half to 2/3 the people, and they're not reaching remission, we're going to call that treatment-resistant depression and start to approach it with that definition in mind. Why do we care about TRD? So we realize that there's a more severe and protracted course of illness for patients who have treatment resistance, and they're also hence, just less likely to remit, and they have partial response. They tend to attempt suicide more often, and also they do not achieve that remitted state which we want. The reason that is important is because when somebody reaches remission, that makes it more probable that they'll have recovery in major depressive disorder and makes it less likely that they'll have a repeat episode. And on the converse, you can think of it as if you don't reach remission, then you're more likely for your patient to have another episode of depression or continue to stay depressed to some degree. So the overarching aim really in treating major depressive disorder is to achieve that fully recovered state where the person is no longer experiencing clinically significant symptomatology and or functional impairment. So now that we know what treatment-resistant depression is, this is one of the ways of staging it, the Thais and Rush staging model. There's various stages from 1 to 5, and stage 2 essentially correlates with our definition of treatment-resistant disorder or depression. And so stage 2 to stage 5 really is all those resistant pieces of depression. Factors that correlate to treatment-resistant fall under various categories. I tend to define them as biological, physiological, psychosocial, clinical, then genetic, which is part of biology but just a slightly distinct category, and then personality factors. Looking at those factors, biologic may include neurotransmitter dysfunction, HPA axis disturbance, abnormal neural activation, and also activation of the inflammatory system. Psychosocial would include factors like melancholic features, psychiatric comorbidity, not reaching remission, and then also a high frequency of stressful life events or trauma. Genetically, there's only a few things that we've clearly been able to identify, and those include polymorphisms in the serotonin transporter region, promoter region, as well as some interactions between BDNF and NTRK2 polymorphisms that we probably don't have the time to go into detail about. And then finally, personality factors, including personality dysfunction, neuroticism, and then, those big 5 personality factors within those: low extroversion, low openness, low conscientiousness, and then high levels of social inhibition. So what do we do now that we understand what the problem is and what we're really dealing with? Going back to our Tiramisu approach, my suggestion is to make the world a better place. And the way we may do that is by, really using that approach of holistic, layered treatment, using all available treatment modalities with really the goals of symptom remission as your overarching goal, enhancing the patient's well-being even in small ways, really aiming to prevent future episodes, and then focusing on improving their quality of life even if they have some residual symptoms. And ingredients for success in being able to apply this layered Tiramisu approach would be to use psychotherapy as sort of the binding agent, which really helps hold your treatment together, thinking about empathy, connection with the patient, etc. Using psychopharmacology is the substantive treatment that affects the biological outcome a little bit more directly. Using nutraceuticals is the cream cheese to make things a little bit more potent and making sure that the patient's own physiology is supporting their healing. Using CAM therapies, which can sort of soak in and help provide a degree of well-being additionally. And then finally, using neurotherapeutics added on as sort of the sprinkling on top to see what else we can improve and make sure that that biological impact we were hoping to have with psychopharmacology can really be supported and made effective. Basic principles for treatment are things we're all pretty familiar with, using the biopsychosocial assessment, getting collateral, making sure we really think through our diagnoses and have a differential in mind, establishing therapeutic alliance, supporting patients' education, self-management, developing goals, developing a management plan that's pretty comprehensive, using evidence-based treatments, and finally monitoring outcomes. Looking specifically at the psychotherapy piece when it comes to treatment-resistant depression, we'll go through a few studies which may help you see what approaches specifically in psychotherapy have been studied. So common psychotherapeutic modalities used are CBT, IPT, behavioral activation, mindfulness-based cognitive therapy, and ACT. So the ones on the left are the ones that have a lot of pretty strong data. The ones on the right are ones that have also shown benefit, but may have slightly limited data. And CBT really, per the information that is available to us just from the degree of data, maybe because it is slightly more time-based and more open to measurement, is that we've seen that it is the most established and has the most evidence, and hence it's considered first-line treatment for non-refractory depression. However, we'll look at some ways that it can also impact treatment-resistant depression. So choosing patients for psychotherapy can be an important piece. We want to make sure there's no psychoses. Melancholia is a little bit lower because in melancholic depression, the biological treatments are a little bit more impactful in the beginning. And then you want to use patients who have limited response to psychotherapy. They prefer psychotherapy, and that also there is access to psychotherapy in their midst. Since a lot of people likely on the webinar provide psychotherapy services, it may not as much apply to you, but really for some of us who are referring patients to psychotherapy, it can be an important thing to know that in their area there's somebody available. So looking at CBT for treatment-resistant depression, there was this study done, meta-analysis that was published in 2018 that looked at 6 RCTs, which involved 800 plus patients. The therapies used included CBT, MBCT, RF-CBT, which if somebody doesn't know, that is rumination-focused CBT. I really only recently learned about it myself. And then another one of the RCTs was done on smartphone CBT. So these randomized control trials were looked at and their data was pooled. And looking at that, it seemed that patients who received CBT while having treatment-resistant depression had higher response and higher remission rates. And the response and remission rates when compared to the control population were almost double. So that's quite impactful. And here we can look at the forest plots for these meta-analyses of post-treatment depression scores. So the first one is for immediately after completion of the CBT treatment, and then the second one, which is on the bottom half of the screen, is for 12 months after the treatment was completed. And you can see on the left side of the vertical line that those are all positive correlations. And then another study for ACT treatment for TRD. This is a manualized ACT intervention. It was a pretty small N of only 19. You can see the inclusion criteria as well as the intervention that was done for only 4 weekly sessions, which each lasted about 3 hours. They did a pre and post assessment, and then we can see on the following slide the outcomes, which showed that there were improvements on self-kindness, common humanity, as well as mindfulness subscales. And ACT was seen to be specifically of value in comorbid medical conditions. Finally, another study on trauma-focused psychotherapies used for treatment-resistant depression. This was a single-blind RCT with an N of 22, so a relatively small sample, but they evaluated EMDR and focused therapy as adjunct pharmacological treatment. Patients did 3 individual sessions. Each lasted, 3 sessions per week, each about an hour long over a period of 8 weeks. And patients were also assessed for exposure to childhood traumatic experiences. And when they did have childhood traumatic experiences, those are the patients who were included in the study. And the results showed that trauma-focused psychotherapies reduced depression, and the outcomes were about 75% remission in those who were treated with EMDR plus psychopharmacology, and 50% for those treated with trauma-focused CBT plus pharmacological treatment. So really great outcomes, and I think that's very encouraging for those of us who take that trauma-focused approach to our care. And finally, some guidelines overall for using psychotherapy for a patient suffering from treatment-resistant depression. Again, you can look at these slides later, but the big thing is to keep short-term goals and really, instead of taking a backseat, take a pretty active role, provide psychoeducation, and lean a little bit more towards coaching and trying to help the patient make those decisions, because as we know in depression, patients' cognition isn't quite up to par, and they're not being able to quite as easily think through their choices and make decisions. Continuing those guidelines, make sure to have shorter sessions, really stay aware of rifts in therapeutic alliance and trying to proactively manage those, providing homework assignments and in-session rehearsal. So sometimes I think about my patient who a few weeks ago I was treating, and really the simple intervention of asking him to make sure he went to all the residential treatment sessions over the course of one day seemed to have made a huge impact to his care. We sort of, shook hands on him trying just for one entire day to attend everything that was on his schedule. And this was somebody who was not getting out of bed at all. And giving him that one goal of let's not say you have to do that throughout your treatment, but just that one day helped him get such a boost in his own confidence and his ability, and to some degree behavioral activation as a result, that really changed the final outcome, I would say, of his treatment here. And then moving to psychopharmacology, which, as we know, is biological intervention, acts in a lot of ways, and looking at that as an intervention for treatment-resistant depression. And we take a little bit different approach than this pursuit of happiness cartoon you see, because we don't want to just give pills without thinking about what we're doing. So really trying to take a mindful approach to psychopharmacology, especially for a patient who's not responding very well to a few treatments that they've already tried. So these are all lists of medications, types that can be used. There's adjunctive agents. We won't talk about those in detail, but we'll look at a few of the studies that apply. So the first one we'll talk about is STAR-D, which was the sequence treatment alternatives to relieve depression study. So this was a naturalistic study. It was one of the largest studies done in psychiatry a few years ago. And this is really important because this was one of the studies which really helped us see how patients truly do in sort of a stepwise way. So the trial was completed in 2006 and data has been available since 2008. This was not a randomized controlled trial. There was no blinding. The doctor knew what they were giving. The patients knew what they were receiving. And there was over 4,000 patients enrolled. They had multiple steps, which we won't essentially go into detail right now, but this is really meant to be generalizable. And the results showed that in the first step, patients responded about 33%. Then the second step of treatment, only about 25% remaining responded, then 12 to 20%, and then 10. So that really shows you that even though up to about 70% of patients reach remission, so the 2/3 number that we were coming up with, that with every successive step of treatment, you're getting a lesser and lesser positive outcome. So the big takeaway was that the patients who reached remission, they actually tend to function better and relapse less than those just with a partial response. So the patients who reached the remission, they tended to have lesser incidence of depression episodes later on. And so the iSpot study is another important study. This was held in multiple countries, including the US, Australia, Netherlands, New Zealand, South Africa, and UK between 2008 and 2013. This was sort of a personalized neuroscience study. They looked at biomarkers for major depressive disorder. They enrolled over 2,000 patients in the adult age range. Out of this study, it sort of came that most medications had the same outcome. But escitalopram, venlafaxine, and sertraline came out a little bit better off than others because of sort of tolerability and efficacy data. The big takeaway for our purposes is that depression with anxiety was harder to treat, and that more severe depression was less likely to go into remission. So that's, again, one of those things where the comorbidity of anxiety was really the point that changed what kind of treatment we needed to do. And so other evidence-based treatments are listed on this slide. We won't go through them in detail for the sake of time. Psychopharmacology strategies for treatment-resistant depression. So really adding, instead of just switching out a medication, adding a second antidepressant with a different mechanism of action, and thinking about mechanism of action as sort of your way of deciding what you need to do next. So instead of replacing Zoloft with Prozac, why not think about something that's in the SNRI category instead? And then second strategy can be to add an atypical antipsychotic. Those would usually be an adjunctive treatment and using something that's FDA approved. Then another thing that has been studied is addition of lithium or addition of T3, which is your thyroid hormone, or addition of buspirone. Some of the ways to decide about that is lithium is helpful for patients with some mixed features, or more so if they have suicidal ideation as an adjunct. Triiodothyronine, or T3, can be added as an adjunct if the TSH is higher than 2.5. That's where the best outcomes are. And then buspirone usually for patients who have comorbid anxiety. Psychostimulants are also used as adjunctive treatment and can seem to be beneficial, especially in older patients. And then finally, glutamatergic medications. At this point, there's about 10 to 12 different glutamatergic compounds under study. So if you go to clinicaltrials.gov, you can really pull those up. But at this time, some of the data that we have is for something like ketamine. And as most of you may already know, earlier in March, intranasal ketamine was FDA approved. So IV ketamine is not FDA approved for depression, but there are quite a few studies, and we'll talk about a few of them. And then also medications that modulate glutamate indirectly can also be beneficial, and that's where we were saying there's a lot of glutaminergic compounds that are being studied at this point. But we're a few steps away from having something efficacious. Then looking at this study, as we said, for ketamine antidepressant efficacy, they had an N of 72. It's a randomized controlled trial. They compared ketamine to midazolam, which is also a short-acting anesthetic, and patients who were brought into the study were patients with treatment-resistant depression. We notice here on the slide that ketamine, which has the little like red squares, is marked in the red squares, and midazolam with the orange triangles. It appears that ketamine seems to have much better outcomes than midazolam, which is sort of an active control that's used. And you see a reduction in depression right at day 1, so less than 24 hours after the ketamine infusion was given, and that improvement is maintained over a period of 7 days. So similarly, this other slide with bar graphs showing the same outcome. Starts right at day 1, goes all the way through day 7. Another study on IV ketamine for treatment-resistant depression. In this, they had about 64 patients. It's a double-blind study again. They used intravenous ketamine or just intravenous placebo. And patients were given ketamine 2 or 3 times weekly. So the purpose of the study was really to see how frequently ketamine should be dosed. And they actually found that, yes, ketamine does separate from placebo, and that continues with twice weekly as well as twice weekly dosing, as you see from the graph on the left side of the screen to the right side, that really the outcomes are not much different. So the recommendation is that, maybe twice a week is good enough, and we don't really need to dose it 3 times. The other thing to remember about glutaminergic compounds is that too much glutamate is bad too. So giving too much ketamine can mean that it can actually be neurotoxic to the patient and not good for them. Finally, anti-inflammatory immune-based treatments. There have been studies in celecoxib and some NSAIDs which show that they're capable of reducing depressive symptoms when used as adjunct, and then also this one study on TNF-alpha done by Chuck Raison et al. In 2013. And we'll look at that one a little bit more in detail. So this was a trial of tumor necrosis factor antagonist infliximab for treatment-resistant depression. And as you see in this first graph, infliximab, which is marked by the solid dots, seems to actually have better efficacy than placebo in reducing depression. However, if you look up on the graph's detail, these are for patients who have an increased CRP or C-reactive protein concentration. So CRP is a inflammatory marker which shows that inflammation is increased in your body. And so when patients actually have increased levels of inflammation, using something that is an anti-inflammatory improves depression. And then you look at the second image where you see that actually using TNF-alpha antagonist or using an anti-inflammatory makes depression potentially worse, or that placebo is better. And in this case, these are patients whose C-reactive protein levels are normal and less than 5. So really that is the thing that we're finding with anti-inflammatories, that yes, if you do have inflammation, then using the anti-inflammatory with the antidepressant means good response. But if you don't have inflammation, then we might be doing a disservice to the patient by adding the anti-inflammatory. Moving on to our next step of nutraceuticals. I like to believe, that food is more important than just supplementation. So my big piece on nutraceuticals is to really try and help our patients see a dietitian, see a nutritionist, and help them truly improve their diet to a more anti-inflammatory, whole foods style diet but we'll talk a little bit about nutraceuticals or specific nutritional pieces, since a lot of the times helping our patients make that nutrition shift is harder. So things we'll talk about are SAMe, omega-3 fatty acids, folate, iron, zinc, vitamin D. SAMe, when you look at that as adenosylmethionine, it's actually a amino acid. When supplemented, so given as adjunct to all other treatments that we're now doing for treatment-resistant depression, they actually seem to have efficacy and safety equivalent to conventional antidepressants. They're safe in pregnancy per some studies done for intrahepatic cholestasis of pregnancy, where SAMe was used for that instead. It is unstable when exposed to air or water, so usually a blister pack should be used. May consider taking it with folate and B12 because sometimes it can unmask their deficiencies. And then finally, the dosage should be between 200 milligram to 1600 milligram per day. The usual recommendation is to start with 200 twice a day and then move up. And then omega-3 fatty acids, there's a lot of studies supporting their use in depression. It's also seen to be effective in bipolar depression. For treatment-resistant depression, it's usually used as an adjunct. The dose range is listed on your slides. And the big thing really is to use EPA dominant formulations, since they are seen to be superior in their outcomes for alleviating depressive symptoms. The ratio of EPA to DHA should be 3 to 2 in the formulation that patients are taking, and to really take it at a substantial dose to effect some response. And then finally, the duration of treatment should be 4 to 16 weeks is what has been studied. We're not saying patients can take it beyond 16 weeks, but I think it does warrant some reassessment at that time. Folate is another thing that's been studied for depression. There's about 2 narrative reviews and 1 retrospective analysis that's been done. Most of these were small samples, so there's not a whole lot that you can take from it, but it does seem that L-methylfolate is seen to have more positive evidence when it's used as 15 milligrams. The study looked at using it at 7.5 and 15, and it seemed that at 15 it actually separates from placebo. The other thing is to consider it mainly in patients who have the 5-MTHFR polymorphism. And again, it's used as purely adjunctive. So this, all these nutraceuticals we're talking about, none of them are supposed to be used alone. Vitamin D has a pretty clear link with depression. However, results of supplementing vitamin D once a patient is depressed and deficient are a little mixed. So we usually think that when patients have a history of depression, that's when correcting the vitamin D level may be most beneficial to prevent future episodes. But if, say, you were to find your patient with depression currently to have low vitamin D levels, you would still want to correct them more so for the sake of helping them out in the future, but you really would not expect to see their depression symptoms change purely with you giving them vitamin D supplementation today. The ideal level is a little bit in question. I tend to go with 50 to 75. Higher than that, it seemed to be associated with some stones and such, but again, there is a little bit of flexibility in the level based on just the debate that is present in the limited data that's available. Usual maintenance daily dose is about 2,000 international units per day. So iron and zinc, these are both really only recommended to be supplemented in deficiency. So iron if the ferritin is less than 50. And for both of these, it seems like their supplementation helps improve outcomes in depression. Now finally moving on to CAM therapies, and then we'll do a pretty brief review of the last bit, which is neurotherapeutics. So complementary and alternative modalities, there's quite a few of them. We think about light therapy, exercise, yoga, acupuncture, and the reason we'll talk mainly about those is because there's the most sort of consistent data in those. And again, these, similar to the nutraceuticals, really only have an adjunctive role in treatment-resistant depression. So light therapy, there's an 8-week RCT with 122 patients that I looked at, which showed that light therapy dosed at about 30 minutes per day at 10,000 lux of fluorescent light seemed to show a decrease in the MADRS score, so increase in depression rating scale, as well as increased response and remission. So when you look at the results, you see that combination treatment seems to have the most response and remission, highest response and remission rates, and the most significant decrease in the MADRS score, but also using light alone or fluoxetine, that is Prozac alone, seemed to affect a change in the MADRS and increased response and remission. One of the reasons that fluoxetine alone may have been slightly lesser than light alone, etc., was because they used a very low dose of fluoxetine in the study, only 20 milligrams, so not a very substantial dose at all. And so this is a type of treatment that's very effective as well as well tolerated, not just in seasonal depression, but also in non-seasonal, as the study tells us. And then looking at exercise, so this is a forest plot of this meta-analyses of 39 RCTs, and most of them seem to favor exercise. There's a few that did not seem to show exercise had a positive impact. And this did study over 2,000 patients with a pretty broad age range, mix of male and female patients. So there does seem to be some greater reduction in depression overall by addition of exercise. And again, this did not seem to differentiate between just muscular or cardiovascular exercise. Study on yoga, which is one of the most commonly used mind-body interventions. It also is a systematic review and meta-analyses. It seemed to show that yoga was beneficial. It had the positive correlation. However, it's sort of a moderate strength of evidence. The big thing that I took away from this meta-analyses and review was that meditation-based yoga interventions were really more effective. So just doing the asanas or the postures or doing sort of a yoga in your gym may not be the effective way of getting that benefit for depression. So looking at acupuncture, this is a huge review done by the Cochrane Library, and we look at various types of acupuncture, including manual electro laser, and it showed that there was low quality evidence for reduction in severity of depression. So it did help, but it was sort of not the strongest evidence, so to say. Finally, switching to the final little piece in the baking of our treatment-resistant depression treatment dessert is neurotherapeutics. And there's various neurotherapeutic modalities. There's rTMS, which is gaining popularity, thankfully, ECT, which has been present for a while. There's also these transcranial direct current stimulations. And I think at the time of me putting together these slides, I had bolded the ones that had FDA approval, but now there is a transcranial direct current stimulation device that actually also has been approved by the FDA. It's called Alpha Stim, and that just got approval in the past month, so ideally that should be bolded too. And we'll talk about a couple of these in the next few minutes. So looking at TMS for treatment-resistant depression, I really like this study. They seem to have studied, multiple, quite a large bunch of patients, about 300 plus patients, and they all received left dorsolateral prefrontal cortex stimulation in their acute phase initially, and then they had long-term follow-up thereafter. This study seemed to show that TMS does statistically and separate out from placebo one, and that it actually maintains improvement over time for patients who respond initially. So not all patients responded, but the ones, so you see them broken up into partial responders, and remitters. And whatever degree of improvement the patient had with RTMS initially actually maintained that pattern of sustained response. And that symptom emergence, if at all it occurred, it usually occurred in the first 6 months of the treatment. And then another study for treatment-resistant depression looking at prefrontal transcranial magnetic stimulation. They had about 200 subjects. Most of them had depression for less than 5 years. They hadn't had prior exposure to TMS. In this study, just looking at the results, it appeared that relapsers who were followed for up to 3 months seemed to continue to have improvement, and that patients who actually had a higher number of medication failures tended to need bilateral TMS. And then when patients actually relapsed after receiving TMS, they usually tended to start deferring from or separating out from patients who continued to have remission at about 1 month. So that might be really the time to recheck with the patient or follow up with them is 1 month after they've achieved remission from TMS, because the ones who are going to relapse will likely do so at that time. ECT for treatment-resistant depression. ECT has been used for over a century in psychiatry, and it's really the problem with ECT at this time is that most often it's used later in treatment algorithms. And the takeaway from all the studies in TRD is that we need to use them earlier, and we need to use them not just earlier in the algorithm, but also when the patient has a severe depression, use it pretty early on rather than having them stay depressed for 6 months or 12 months prior to thinking of ECT. I personally used to do ECT or perform ECT till about September of last year. And I think if it's done in a mindful way and your patients are carefully chosen, you can have excellent results with fairly limited cognitive impact. But again, it's a patient you have to assess and figure out who's the best patient for ECT. And finally, deep brain stimulation. So these are the inclusion and exclusionary criteria. As you see, they're pretty vast. And DBS, as well as vagal nerve stimulation, which was one of the other things I had mentioned on that initial slide, both are usually used as one of the last resort treatments. You actually have, wires and electrodes in your body. For VNS, it's stimulating your vagal nerve. For deep brain stimulation, you actually have an electrode that's inserted by a neurosurgeon in your brain. And then there's a little device, kind of a remote almost, or the control panel that's inserted over the chest wall for the patient. So it's right under their skin and you can kind of feel it subcutaneously. And these are pretty invasive treatments, but these are also fairly effective treatments. So when you look at DBS, there's about 3 sites that are considered as effective sites. So there's a subgenual cingulate, ventral capsule, and the medial forebrain bundle. These are used as last resort treatments for highly resistant patients. But the good thing with this is that you do have a psychiatrist who's highly skilled, who's working with you, and they truly take a remote and, control your mind and try to treat your depression. But these are last resort treatments that should be considered if your patient has failed all the various levels prior to this that we've spoken about. Finally, going back to tying all of these in, and all I can say is that, treatment-resistant depression is a very complex entity, and we shouldn't try and say, okay, well, I do this, so this type of treatment is all I can do. We all have very specific trainings, very specific skill sets, but these are patients to whom we owe being able to work in a collaborative, team-based model. So even if you work alone in an office, to build a network of colleagues who you can refer to and receive referrals from. So these patients who are suffering so deeply and having such a huge impact on their life, we can use psychotherapy, psychopharmacology, help them go to a naturopath, get some nutraceuticals, get involved in CAM therapies, and then really not shy away from neurotherapeutics. Most people tend to think about neurotherapeutic strategies as last resorts, and really only deep brain stimulation or VNS would be considered somewhat on that last resort end, but the others need to be integrated early on and pretty actively in the treatment. And the hope is that there'll be this sweet result of a beautiful tiramisu and a delicious life that our patients can have. And for any of you wondering what happened about my withdrawals from tiramisu, I have been able to find in Tucson, where I live, a really wonderful bakery that does tiramisu cupcakes. So I'm also having some sweet results on my end. Thank you so much for sticking with me through this presentation. Here are my references, which you'll have on the slide set, and we'll transition into questions at this time. Received a few, so I'm going to start reading through them and trying to reply to them to the best of my ability. Thank you for sticking with me through this whole process. So the first question is, will you discuss the relationship between treatment-resistant depression and CTE? I'm guessing CTE, the person who sent this question is referring to chronic traumatic encephalopathy, which other people would understand as repeated concussions, so to say. Not really. I haven't looked into that quite as much, but for the person posing this question, you can feel free to email me later, though we do notice that with concussion, there's a lot of other cognitive changes that occur, especially for people who have repeated traumatic injuries to the brain, and that can lead to some frontal lobe changes and hence personality changes and cognitive and mood changes associated. But if you need any assistance for treatment-resistant depression and CTE, we can talk about it at that time. The next question is, what is smartphone CBT, or where can I get information about it? So there are a lot of apps out there for smartphone CBT. I'm not aware of all of the ones that are out there. There's one called Mood Gym that people use, so that's mood and then gym, kind of like you do a workout, that people have used that I've known and found that to be effective. The study that I had cited was actually out of Japan, so the app that they mentioned does not seem to be available in the English language. For any of you who are hoping to recommend CBT apps to your patients or clients, you can go to the American Psychiatric Association website, and they have a criteria for how to select good or effective apps, and I would really suggest looking through those criteria and making sure that anything that we're recommending our patients sort of meets that stringent criteria. The next question, for the ACT add-on for the psychiatric facility, were the patients in the inpatient or different level of care, and does the high structure environment make a difference in the effectiveness of treatment compared to those in outpatient services and navigating their natural environments? In terms of this, the ACT study that I had mentioned in the slide set was actually based at an outpatient facility. So this was an outpatient clinic, so there really wasn't the residential or inpatient level of care. And as we noticed, there was almost double the improvement in patients who were just taking medication. So that addition of ACT is really seen to be effective. It seemed to be a fairly time-consuming study, but treatment, since the patients were in groups of about 3 hours each, but each group had about 6 patients. So I think it was a fairly effective intervention for a set of patients who we see are fairly treatment resistant. Next question, somebody asked about CAM therapies and neurotherapeutics. I'm hoping as you went through the slides that became clear. Another question regarding asking me if I have used amantadine as an adjunctive agent. The answer to that is yes. I've used it in a handful of patients, and I'll start with maybe 100 milligrams and see how they do, and sometimes go up to 200 milligrams, and it can be effective. It's a good adjunctive agent once you've exhausted other options. But again, as we know, there's not adequate um, there's not adequate research data or an RCT done with addition of amantadine, but it has been shown in small trials to be effective as an add-on. The next question I have here is if there is any data on EMDR and depression. And yes, there is. There's small studies, one of which I had mentioned in the presentation, where it does seem that if patients that we're treating have a history of trauma, so there may be the value of doing a really thorough intake and getting a detailed trauma history. And in the studies that I've seen, they've actually done trauma questionnaires and made sure that, especially if the patient had early developmental trauma, EMDR was seen to be effective as an adjunctive treatment along with medication for depression. I have a lot more questions that are coming through. I may not be able to get to all of them, but I'm going to try. Next question, the person asks, my biggest challenge in working with depressed patients is their motivation to seek such treatments. With so many options in the Tiramisu approach, it may overwhelm someone with TRD. If you had to prioritize ingredients or have any tips for helping them follow through with treatment, what would that be? And I think the answer to this is obviously not simple, and I think the person raises really great points about patients not really being motivated. When patients are really in a very low spot, the most important thing at that point is trying to do the most effective treatment. And at this time, the most effective immediate treatment is still medications, and it can be addition of psychotherapy, though sometimes patients can be so depressed that they can't really engage in any active cognitive piece of therapy, and you may want to use behavioral activation as sort of your starting point. The other thing is if the depression is very severe or if there's continuing symptoms of, say, psychoses or worsening symptoms in that regard, then you might want to go to neurotherapeutics as one of your first steps too. So you can start a medication, but at the same time, offering RTMS if it's moderate to severe depression that is not responding to other treatments. And then finally, considering ECT if the patient either has suicidal thoughts or has symptoms of psychosis associated with the depression. So that would be the way to prioritize. And then other ingredients of the Tiramisu approach is really more so to make the person's life more fulfilling. So you being able to add CAM therapies will really support their biology and healing. And being able to give them nutraceuticals and other things may give them a little bit better control of their treatment and not feel like the entire treatment is in the doctor's hands or, you know, there are all these outside people who are controlling what I have to do, but to give them a sense of self-efficacy as well. And then question about studies around aromatherapy. There are small studies. They do show some benefit, but usually it seems to be more in the anxiety realm. There's not stringent or large enough studies to really make a determination at this time. I would say since it's, you know, if it's low harm aromatherapy, which is usually the case, and the patient feels like it's helpful, I would use the placebo positive effect and let them use it. A question about treating, where the person asks if I have any thoughts on treating catatonia in depression. Yes, I have lots of thoughts on that. And catatonia is something that I also feel fairly passionately about. If your patient has catatonia and depression, the gold standard is to use ECT as your main line of treatment. So I would go with that. There's a lot of other adjunctive treatments that can be used. Obviously, with ECT, there's stigma, and so one may need to work with that and work with the family to try and motivate the patient for treatment. For catatonia, you can also use antidepressants. Some people start to look at catatonia as an aspect of schizophrenia, and I would really ask us to move away from that. We very well know that now catatonia is a syndrome that can be present with various different mental health conditions, including depression and schizophrenia, which is more common. And it can also be secondary to medical conditions. And I think that's a piece that we as mental health providers often forget, and our colleagues who practice physical medicine or medicine in other realms also tend to forget. So catatonia is a pretty clear syndrome in which I think ECT would be best if the person is willing to agree to it, or otherwise at least treating the underlying cause. If it's schizophrenia and then catatonia, then you want to treat the psychoses. If it's depression and catatonia, you want to treat the depression. If it's secondary to a medical condition, you may want to get a CL or a consultation liaison psychiatrist involved, or even a neuropsychiatrist who seem to have a little bit more experience sometimes in treating those conditions. Next question, has there been any results from preliminary research to the efficacy of psilocybin or other hallucinogens in treating MDD or TRD? Yes, there is preliminary research, and it's looking very exciting, but it's also, most of the preliminary research is very stringent and done with keeping the set and the setting in context of the use of hallucinogens. So given that these are potential substances of abuse and have traditionally been used in more of a spiritual setting, I think we need to tread very carefully. And we're really thankful to, I think, NIMH and other organizations that are supporting study further of psilocybin rather than just, making it a thing that was in the past and died in the 1970s. So there is new research coming in for psilocybin and other hallucinogens in MDD as well as for OCD. So we'll keep on talking about that in the future. Another question where somebody is asking if Abilify is still often used to help as a catalyst for more typical antidepressants. And they go ahead to state, I often see it prescribed in conjunction with antidepressants, but have heard a lot of contradicting studies that say Abilify does more harm than good for the body. I'm not sure what studies you're referencing, but Abilify is FDA approved, and there have been phase 3 trials, which obviously are run by the pharmaceutical companies, that do show that Abilify used as an adjunct to an antidepressant, so an SSRI, SNRI, et cetera, is effective in improving symptoms of depression. But that really is in context of major depressive disorder, unipolar depression. In terms of bipolar depression is where Abilify has negative studies where it shows that using Abilify for bipolar depression is not effective. But if you have more questions specifically on this harm to the body, I would say send me an email and we can talk about it. Okay, and I think we'll take one more question and then end it. So there's a person who asks, says, I work in a federally qualified health center and we work with Medicaid patients and those who are uninsured. We offer pharmacology and psychotherapy in a brief treatment model. How do patients on Medicaid or who are uninsured seek CAM and neurotherapeutics? Are there options for them? I think a lot of patients are seeking CAM therapies on their own. A lot of communities have co-ops for acupuncture. Yoga can be a fairly, cheap class that people can take. There's yoga studios that are sprouting up in various parts of the country, and most of them for anywhere between $5 to $7 a session, people can go do yoga. So if they were to go to a facility like that a few times, and now there's also online modules for yoga. The person can open up a YouTube if they have a smartphone and work through some yoga asanas. I think the big thing for us to explain to them is that if they're going to be doing yoga, they need to focus a little bit more on the mindfulness aspect, and which is why maybe going to a true yoga studio a few times will help them learn that, and then they can kind of carry it on their own. Acupuncture, like I mentioned, there's co-ops. There's one here in Tucson. You can go in. These are people who are in training for acupuncture. So you just, give whatever you want out of the kindness of your heart, or certain places they might charge $10 or so for a session. Neurotherapeutics, especially ECT and TMS, are covered by most insurances. Medicaid often in various states will require that you show that they've failed other treatments before they'll allow TMS. And there's maybe not as many TMS practitioners as we would like, but a lot of insurances are covering those neurotherapeutic treatments, the main two. So I would really say to try and work with your insurance reviewers and work with your model to try and get that approved. I used to do ECT in a community hospital, and we always managed to get that covered for patients. And I think we're almost at the end of our time, so I'm going to end the reading through the questions. I think I had still about 10 that I have not read. So for anybody who sent through questions and would like those answered, please feel free to send them to me directly. My email address should be available to you from here. And as we end the session, I think the next page will take you to be able to get your continuing education credits. Thank you so much again for joining us today, and hope you have a wonderful rest of your week. Bye-bye.